Thank you. The meeting for our Zuckerberg San Francisco General Hospital and Trauma Center Joint Conference Committee for July 28th, 2025 is called to order, and we'll ask the secretary to call the roll.
Sure. I'll start with you, Commissioner Chow.
Present.
And President Green.
Present.
I'll note that Commissioner Christian is out ill today. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the June 23rd, 2025 ZSFG JCC minutes.
So the minutes are before us for approval. Is there a motion?
I'll move to approve the minutes.
And I would second. Is there public testimony?
There's no one's been approved to provide remote public comment. Everyone in the room is staff. So I would say all those in favor.
Aye.
Thank you. We can move on to the regulatory affairs report.
Good afternoon, Commissioners. Emma Moore, Director of Regulatory Affairs. I'm here to provide the July Regulatory Affairs report. So first up, you can see our pending surveys. I know there were a couple of questions about those, so I'll try to address those as I go. So the first one had to do with the very first pending survey there, the CMS outpatient dialysis recertification. I do not have a concrete time frame as to when it might occur. It could be any Monday or Tuesday. It's typically a week-long survey with 2 surveyors, though that can vary. But what I will say is that our kind of general understanding of CDPH's focus is that they've been primarily focusing on skilled nursing facilities and other things that CMS has been giving them pressure on, such that some of the lower priority items from their perspective have been delayed. As you can see, we last had this survey 8 years ago. What I will say is that they are anticipated to get a new space. The last update, which I may not be the most knowledgeable about, but was that space will be finished from a construction standpoint in October, and then we will start the licensing process then. That it's possible that get the licensing survey of that new wonderful space may trigger the recertification, and whether that happens concurrently, that they decide to just throw everything at us, or that it's that they license the space and then soon come out within weeks after that is highly possible. The next one on 4A licensing and recertification, we are in the window for both. Recertification, again, is typically annually. And to the question about remodeling 4A, so just to clarify, it was a seismic upgrade. And from a CDPH standpoint, we are saying that was the extent of the, they did not physically remodel the space. They are still all double rooms that exist. They did not provide us an extra survey when we put the beds in suspension. As of yet, they still could, but when we put those beds in suspension when the unit closed and then when it reopened. So we are at this point anticipating that they will simply come out for the recertification. It is possible they may also do something associated with that bed suspension and then subsequent reopening, but at this point that has not happened. And so that kind of is our pending survey piece. We're still watching and waiting with bated breath. Moving on to section 2, the survey activity, you can see there that there was a respectable amount of survey activity in June. So there was one complaint about the kitchen where DPH came out. There were no findings associated with that. There was also a newborn screening program site visit. No issues at all with that, as well as 2 inpatient psychiatry sexual assault allegations, no findings associated with those. And then lastly, the Behavioral Health Center, specifically the 3rd floor, the MERC, had their annual relicensing survey with DHCS. There will be some findings associated with that, but they were all preliminary. We are waiting for their final report, which sometimes can take 6 to 9 months. But all of the findings were minor in nature, and the team is already working to kind of preemptively address them. And once we get that official report, we will make sure that it is included and reported out. Next up, under plans of correction submitted, you can see there that we did submit our Joint Commission stroke certification plan of correction, and it was accepted by the Joint Commission. And there were 3 findings associated with that require monitoring. So no documentation of individualized education for new medications prior to discharge, no medications of when or not documentation rather, of when or who the CT read was communicated to for a TIA case, and then no documentation about risks and benefits of new medications at the time of admission. So all of those have been well addressed. I want to actually give a shout out to that team because in all three cases, they were able to do some work in Epic to kind of make from the hierarchy of changes to make some more structural changes rather than just re-education, because we know that that's not a consistent change. So they are already working on data. They don't have a full month yet, but everything so far is going extremely well. Next up on the second page, section 4, are CDPH cases. There were 2 privacy breaches, 1 sexual assault allegation and 1 abuse allegation reported in June of 2025, which brings our year-to-date total to 36, as compared to 43 last year. So you can see that we are rapidly approaching last year's entire total. And again, I think it's very clear from the graph that privacy breaches and sexual assault allegations are the 2 main reasons why. In terms of the privacy breaches, Kim Oka, our privacy officer, has been kind of digging in and trying to figure out what has been happening. And as I think I reported last month or the month prior, she has been finding that people are self-reporting more often through the SAFE system, suggestive that that system is working. They have also found, she estimated, I think from digging into the cases, that 75% of them were due to a miss, an accident, carelessness, kind of that accidental piece. It was not malicious. It was not, I'm going to go searching for this famous celebrity's record. It was nothing like that. So again, we are continuing to monitor those to see what happens. The other trend that we want to identify is that of the cases received, of the privacy breaches that happened this year, we've gotten they are typically investigated by the Medical Breach Enforcement Group of CDPH, which is in Sacramento, not our district office here in San Francisco. Brisbane. And they don't typically come out in person. It frequently is record review, sometimes like a Teams or Zoom call. But with, I think, one exception that you also asked a question about, every case that they've given us feedback on has been either substantiated without deficiencies. So they haven't given us a plan of correction. They've acknowledged that it wasn't proper practice, but there hasn't been any penalty or even a response required, or that they've said that per their perspective, it didn't constitute a violation. So I think there is something from a severity standpoint that I'm encouraged by the fact that that is one of our outliers. And the second is the sexual assault allegations, where again, we're reporting any allegation within 24 hours as required by CDPH. But in almost all of the cases, it is not something that we have no substantiation that it even occurred. Moving on to the next page in terms of the plan of correction monitoring data. So you can see there we are almost done talking about our Joint Commission survey from last year. There is one single finding related to the Department of Care Coordination and documenting skilled nursing facility choice for patients, that they're actually getting some new software that's going to be going live called CarePort in October that's going to help with this documentation. So we have a structural fix to address this thing that for 18 months we've been working on but struggling to collectively gain compliance with. So I'm excited that that will hopefully soon be no longer an issue. And the one remaining finding from the inpatient psychiatry complaint validation survey, they just reported out, it'll show up on next month's report, but they've been able to gain compliance. So that will be taken care of as well. The life safety code will be complete. And then you asked a very good question about the 2022 privacy breach. And the reason that that is still ongoing monitoring is we didn't get the plan of correction until I think 2 months ago. So it took them 3 years to investigate it and then send us a plan of correction. I can report that so far the privacy team has had 100% compliance with the 3 items that they are monitoring, having to do kind of with the reporting piece and the education. So I don't have any concerns there, but it is CDPH's delay in investigation is why we're talking about a case from 2022 in monitoring. And moving on to our reports about the complaint data, and then the facility reported incident data from 2023, 2024, and 2025. And we are again continuing to track this, but not seeing any major movement. Bits and pieces here, it does seem like, I think from a pattern trending standpoint, that there have been a few new surveyors who seem to be coming out much more rapidly on their existing cases and closing them. But otherwise, we are continuing to watch and wait, and I think very much acknowledge that in the last 2.5 years that we are keeping close track of here, there's more than 100 cases that are still open without a final resolution. So it's a waiting game for us at this point. With that, I will stop for questions.
There's no public comment.
Well, thank you always for the wonderful report. I was just curious about the documentation of risks and benefits of medications and treatments. If someone comes in with a TIA or a stroke, how can you possibly have an eloquent discussion about risks and benefits when time is of the essence in some of these cases, and when some people, of all things that you could come in with where you can't really assess that complexity, how are they or what's their bar here?
You know, the surveyor's bar was, I'm going to be candid, fairly high. But I will say in the instance that we had this finding, it was a patient that was being boarded in the emergency department. And so there, I think, were some larger conversations the executive team had with the surveyor about flow and the impact. But at the end of the day, from a standard of care standpoint, they still deserve the same level of care that someone on the inpatient unit does. And so one of the ways that they've actually been able to do this is incorporate it into the the neurology residents documentation, so that they have some, I think, smart phrases and some additional built-ins, and the residents are actually taking because it was the stroke-related medications that the surveyor was focused on because of the survey subject matter. And so I think it was still that piece that even though they may not be entirely with it, the expectation is that education is still being consistently done and documented because there was a gap. I will say that anecdotally, you'll get the official report out in the coming months, but that there'd only been one patient that fit the criteria to be monitored, but we have successfully done it with them. So we'll keep monitoring till we have a larger sample size.
Thank you.
Thank you. I don't believe we have any other questions. Thank you very much for the thoroughness of the report and some of the clarification. And we'll continue to follow the saga of the CDPH reviews.
Right, thank you.
Here, let's go on to our next item, please.
Sure. Item 4 is ZSFG hiring and vacancy report. I believe we're doing this remotely. Erica, are you there?
I am. Can you hear me?
We can hear you, but not see you. If you're able to get on
Yeah.
camera, please do.
Oh, there it is. Sorry, I hit the wrong button. Apologies.
There we go.
Apologies for not being on site today. A little under the weather, and I'd rather contain it to my home office rather than getting all of 101 Grove sick. So thank you for allowing the time to do it online. Good afternoon, Commissioner and President. Apologies again for not being in person. I want to just give a high-level overview of the report that was shared last week for the JCC. Our June report, the vacancy rate, for Zuckerberg fell by 0.06% in the last month to 6.78%, or with the attrition savings of 1.06% vacancy rate. We hired 31 employees in June with 6 separations and 1 retirement. Of those 31 new employees, 29 were registered nurses, and we also placed 14 P103s to address the need and fill vacancy gaps. We also continue to hire in other job classes as well. We hired an LVN, a senior pharmacy helper, a medical assistant, a nurse practitioner, and a physician's assistant. From the HR side of the house, outside of just hiring, is that we're working on continuous improvements. We want to make sure that our hiring experience and employee experience is as seamless as possible, both for our hiring managers, our candidates, and those that are going throughout the process. So we're working through ways of streamlining our processes, taking some of the administrative burden off of our hiring teams upon selection, making it easier to say, hey, HR, we're ready to go. We want to make that as simple as possible. That in turn will also streamline our hiring impacts, making it a faster time to fill. So a position will get filled quicker is the hopes that we're looking for by streamlining some of these processes. We're also looking at workload of the hiring analyst of how can we streamline and reduce the meeting times that they are having, reporting out on similar information just to different contingents of folks. So we're looking at consolidating those meetings so that they're spending less time in meetings and more time actually conducting interviews, getting candidates through the process. Again, hoping that will expedite our time to hire. Last month, we did mention that we were completing the employee engagement survey. All the results have been completed. Our employee engagement team is now looking at that data, compiling it, sorting it, all of that, so that they'll be able to then share out with the hiring teams to be able to absorb it and take back any improvements that we may want to move forward. So more to come on that. That should be out sometime. We're thinking probably mid-August, where we're going to be able to make some action items on that. And that is all that I have. I will open it up for questions.
And again, no public comment.
Good. They've answered my question. Commissioner, any questions?
Yeah, I guess I just have a more global question, which is, there was a time not that long ago that there was a tremendous amount of competition for certain skills, especially nurses. And I'm wondering where we are. Are there any subsets of employees where there's still a lot of competition in the area or a shortage? Because obviously you've been so successful with nurses, but how's what's going on in terms of just the ability to find people? We certainly have issues with mental health providers, of course, but what about other classifications? I mean, we've had some issues with housekeeping, for example. So where are we on that?
Great question. And it is, I don't have the data in front of me. So this is, I'm guesstimating right now, but I will definitely come back with some numbers next go around so it's supported. But you had mentioned the behavioral health clinicians. That's something that we do. We have plenty of positions. I think that's part of where the shortage comes in, is because we have so many of the vacancies, being that we're helping street health, that it's growing. That's part of it. And there's just not as many behavioral health clinicians out there as we have vacancies in many instances. So that's something that we're working through. We're also working on LVNs, MEAs, and CNAs also are ones that we are continuing. Those are positions that, from what I've seen, that there's a continuous need that we're working on recruiting strategies for those to ensure that we have valid candidate pools. And RNs will always be, while we've done really, really well, that's always it's always top of mind, because the market could shift in a heartbeat and we may not be in such a great place as we are today. So that's something that's always top of mind as well.
Thank you. Thanks. That's
Absolutely.
Okay, we have no further questions. Let us move on to our next
All right,
item.
thank you so much. We can move on to item 5, the CEO report, Emergency Department newsletter, and Burt newsletter.
Good afternoon, Mark, commissioners, Susan Ehrlich, CEO at ZSFG. Pleased to be in front of you with my report, which has 3 sections now. So I will go through each of those one at a time. The narrative report this month has a lot of celebrations and recognitions. So I will focus instead on 2 items: the capital report and the quality report. So I really appreciate this capital report because it's focusing on something we don't talk a lot about here, which is building our ambulatory center of excellence. And I want to point out that in order to do that, and again, we're talking about Building 5, which is our 1970s era building, we rely on 3 sources of funds, largely the 2016 bond fund, but other bond funds as well. A grant, especially one grant from the state of California, and then our San Francisco General Hospital Foundation. So all those 3 sources of funds come together and will come together over time to build our center of excellence. You can see some small photos of the areas that we're focused on, but there are other places that I just wanted to call out. So first of all, we were talking about the dialysis center that is scheduled to be completed by the end of this year. And that will open on the 3rd floor across from the beautiful rehab center that we finished some time ago. In addition, we have a clinic for cystoscopy and urology, which will be great because those folks will be able to leave the perioperative area and come do their procedures in that unit. We will have a new PES on the 1st floor. That will be in 2027. A new 12-bed acute adolescent psychiatry unit on 7A. This is such a scarce resource statewide. This is the project that's funded by the state grant fund, and that will also open in 2027. We have specialty care and primary care opening on the 4th, 5th, and 6th floors, and then the public health lab on the ground floor. So this is a huge, and then also the lobby and the cafeteria will be renovated. So this is multiple years of work, and I really want to send a gratitude to our capital projects team, which manages these scores of projects, as well as our facilities service team. And our Chief Operating Officer in the audience, Sabrina Robinson, has done an incredible job leading these teams from the executive perspective. The quality team has put together this risk room event, which is such a great educational opportunity for our teams. They did a similar educational effort before with the regulatory report. So you all hear how complicated these issues are, and it's been a really nice thing that they've been able to educate larger numbers of our teams to get familiar with the work that they do. So shout out to them. I will stop there and happy to answer any questions or clarify anything else from the narrative report.
Well, we certainly want to again recognize you, Dr. Ehrlich, for
Thank
Yeah.
you for all the comments you made at the Health Commission meeting. I really appreciate that.
So, could there any questions on the first part of the report? No. And it really is always uplifting to read this first part because then everything is going so nicely. And then, of course, we come to your other parts and they are doing also fairly well. So,
Yes, and we will dig into that. So first I'll start with the True North scorecard, and I will, the main questions you had were on the revenue cycle report, so I'll answer those to the best of my ability, and I have my lifeline with the executive sponsors of that area as well. So in terms of departments driving equity, that is in the green, higher is better. We are at 74.2% versus 65%, which is our target. So that's going well. Sepsis bundle compliance, this is pretty much in the same state that it's been. We are in the red here. Higher is better. We're at 38% versus 59%, which is our target. And the main barrier here is that we need to do a build in Epic. And that's scheduled to start at the end of this calendar year. So we're really excited about that. All of the preparatory work has been done. We're really just, there's a lot happening with our data team and our IT team. So we're working with their bandwidth, and that's when their availability will begin. Falls also in the red, lower is better here. We are so close. We're at 0.08 versus 0.07. As you can see, we've had a really nice downward trend. And here we have a couple of things going on. We have a collaboration going on with pharmacy and nursing around medications, and then also the K-card project or the rounding project that we learned from the ACE unit. They had a great best practice rounding project that resulted in 0 falls for a long time, and so we're trying to spread that. Medications for opioid use disorder, here we're in the red, higher is better. We're at 20.4 versus 22, which is our target. And here, we're really still working on making sure that the data is available to us in order to drive improvement. Okay, so next we have flow metrics, and I'm going to be brief on these because you have a whole presentation focused on flow, and so I think most of your questions will be answered there. Here, the first metric is inpatient length of stay, physical health and observation. And here we're in the red, lower is better. You can see that there's a nice trend down this year. We're at 5.95 versus 5 days length of stay. So I'll let Dr. Ortiz go into the countermeasures for that in more detail. Our psych metrics happily are in the green. First is our percent of acute patients on the inpatient ward. We're in the green, higher is better. We're at 21.8% versus 19.8%. And this is great news because it means that we're flowing better in psychiatry than we have been. And here we see a nice trend up of percent acute patients over time. Same in PES. This is around boarding. This is in the green, lower is better. We're at 57.1 versus our target of 57.8. And here we're Basically, when we're boarding fewer patients in PES, it means we can admit them faster, which is a good thing. Boarding for medical patients, we're in the red, but gosh, it's a really nice graph that we have here. It just means that we've been doing better, but not for as long in the year that as we need to have been. So we're in the red, lower is better. We're at 35 versus 15. Again, we'll talk more about this when we get to our overall presentation. Physical assaults with injury, we're also in the red, lower is better. We're at 6.3 versus 4. And we have several planned countermeasures here. One, we've been in the process of installing a weapons detection system. We have that fully implemented in Building 25 lobby. We're about to go live this week in Building 5. Which is great. We're partnering with security to do updated risk assessment, and we're developing tools to assess and communicate patients who are at higher risk of violence. And we're doing the team is doing a great job looking around the country for best practices for how to do this. Okay, accounts receivable days. So you had some questions in this area. So first of all, on the accounts receivable days, we're in the green, lower is better. We're at 58.3 versus 59. The AR includes all of the days. And so the data that you asked for, Commissioner Green, we're in the process of pulling together, and we'll provide that for you in a later date, insurance versus patient AR. On the percent realized revenue, this is in the red, higher is better. We're at 14.03 versus 14.25. And the issue here really has to do with the way we are processing OBS claims. So this is a new group of claims that we're processing. We haven't yet fully understood all the issues and sorted out all the issues. That's why this is going so slowly. But I expect that this will resolve with time. It's just that the team wants to be very careful with how they're processing these with the health plan. Let's see. So I'll just address your other questions. So the systems having AI involved in diagnostic codes. We have had a coding system that uses AI to understand and suggest codes. In fact, in the budget this year, we are doubling down on the way that we use and apply that with our providers. So it's been successful. We hope to be even more successful this year as part of our revenue cycle work. And then our last one is our denial rate for hospital billing. We're in the red. Again, close. We're in the red. Lower is better. We're at 15.8 versus 15.6. And we have a number of countermeasures here that we can answer questions about if you'd like. So I'll stop on these, our strategic metrics, and see what questions you have before I move into the more standard flow playback.
Commissioner?
Yeah, well, thank you for the clarifications. One of the reasons I asked about patients versus insurers is I would think in many instances patients would be slower to pay than insurers, and you're probably, if you're doing better than what these data say for insurers, you should get credit for it, because patients are a lot harder to pursue, I think, in many ways. So that's the only reason. I mean, you don't have to get the data, but I was just curious. I think you might be doing better than these numbers suggest.
Yeah, we'll dig into that and let you know. Thank you for asking.
And then I wonder if you can explain the OBS, because I mean, I may misunderstand, but it would seem that these health plans would be so much more, positive if you're putting people in OBS status than admitting them from a cost perspective. So I'm wondering, I would think they would be delighted to pay OBS,
So there have
invoices.
been thank you so much, Commissioner Hamilton Zaria, the Chief for Performance and Excellence. So with San Francisco Health Plan earlier this year, we noticed sounds like some sort of like system IT challenges that we've been working through both on our end and on their end. And then we expanded observation services to all payers. And so my understanding from the team is we're we want to get our process correctly for dropping the claims. There's no concern that we're not going to get sort of paid appropriately for that. I think we have been just sort of crossing our T's and dotting our I's to make sure the process is correct. We just can't tell you the impact on the revenue or on denials because those claims we just started to send out in the last couple of weeks. And we did that expansion in February. Eric, anything to add on that?
And you won't be out of timely filing for any of these, right?
No, I know that our team like pays close attention, to that. So I think they've been going out as of the last couple of weeks. I just can't tell you the impact of them as of yet.
Is it San Francisco Health Plan or is it also, I mean, you have some managed Medicaid from Blue Cross as well. Is it uniquely with the San Francisco Health Plan?
The issues previously in the year were focused on SFHP, but now we are sending, OBS is for all payers at this point in our institution.
Fine, great.
And just to add, our patient financial services team has set up a new work queue to monitor these observation claims, and that is causing some of the delays that we're seeing to make sure that we're dotting our I's, crossing the T's as we're submitting these claims, so they don't result in denials.
Thank you. Great. Yeah, the other question I had that it relates to one of the other items. I just got we got a staff email from Sutter that they're starting to use canines as a way of finding weapons. And so they were initiating this huge project in every Sutter hospital. And when you said we've kind of looked for best practices around the country, I have no idea. It was very vague. And there was a link that I didn't look at. But I'm just wondering if that's another thing to look at, since if Sutter's doing it, it must be evidence-based,
Well, Sutter has the same weapons detection system that we do. Noticed that when we were there the other day. The only time we use canines on campus is when we have a bomb threat. And then the sheriff's department brings in a special team that goes through every part of the organization to see if there actually is an explosive device. That's not been the case since I've been around, thankfully. But we're relying on we have metal detection in the emergency department entrance. We use a wand in the ambulance entrance. And then we have the weapons detections system in the two entrances for people walking in, just generally.
Yeah, I was kind of surprised they were adding that because they have the name of the canine and they have the name of the handler. And I'm not sure when they're going to be there, but I was kind of surprised to see they had added that at across Sutter. So
It's interesting.
yeah, it's kind of interesting. So, yeah, that was all.
Do they wander the halls or?
Well, I was wondering about that.
Maybe they double as pet therapists.
Well, I was hoping that would be the case. That would be, definitely good use of manpower, dog power.
That's actually interesting. And, I would have thought that maybe, and maybe we should use that for drug detection. And maybe we should suggest that to Laguna.
Laguna, yeah.
But on the physical assaults, which was my question that I had, understanding that, of course, we have to be able to detect weapons and all, but how many of our physical assaults of staff are related to weapons as versus just?
It's really not. I mean, the assaults are, they're patient on staff or staff on staff, so we really, and our overall strategy is really focused on de-escalation because that's where the vast majority of impact can be made. And so we do the CPI training, we have the BERT team, you've heard about all of these interventions, but that's the main issue.
So, as we've been reading the BERT team information and all, that strikes me then that I'm not sure, as we're looking at all the data, and we see it on a monthly basis, as you've been so kind to keep us up to date. What is the trend? Do you feel that the trend here is down on your chart? Do you feel BERT is a very important part of that, and that you're seeing lesser and lesser calls, or we're seeing more successful calls, or so is it calming the campus, or if not, what do you think your overall success rate? And I guess you're dividing the emergency room from the floors themselves.
Right. So there's a lot there. I would just say at a very high level, over, the last decade, there's just been an incredible transformation here. Because recall, before Bert and, a while back, all we had was the sheriff's department. And we were really focused there on uses of force by the sheriff's department. We really don't focus on that we still talk with them about it every week, but those incidents are few and far between. And now we're really focused on getting at the root cause of why we have violence, which is, really situations that escalate. And we've implemented the BERT team, we've focused on the CPI training. And so I think we've just really had a complete transformational change in the way that we address violence on campus. And in the, just overall.
So this is another theoretical. If there is disturbance on the floor,
Yes.
say, then just to remind me, you're starting with having the floor try to handle it, and then if they don't, they call the BERT. Is that how that works?
Right. So, you'll notice that we have the team that's focused in the ED.
Yeah.
And those folks are there 24/7. There's also a psychiatrist in the emergency department 17 hours of every day. So that also helps with management. But they're just continually rounding in a fairly small space and able to address issues before they happen. There's the inpatient team, and you can see that in the numbers. The numbers are really different between the two. The inpatient team, it's one team in a much broader area. So they're focused more, rather than just, addressing things as they happen. I think they're more focused on consulting with teams about patients who present challenges. So you're correct that mainly we are educating our staff so that they feel comfortable addressing things before they happen and understanding what the signs are of an escalating event. But then they do have the BERT team. And they also have the sheriff's department, but we rely on the sheriff's department far less for these situations, and much more on the teams themselves and BERT.
So let's just say that theoretically somebody is beginning to act up.
They would call the BERT team first.
Then you would call the BERT
For
team.
sure, yeah.
And we wouldn't let something go for a day or two or something. You would think
That's the goal.
that's the goal.
It's definitely the goal.
Okay, so once they see this and the staff feels, gee, we need some help to handle this. And so instead of calling the sheriff's department like we used to, now we're calling the BERT team, which of course we see the success rates in terms of not
Yes.
calling the sheriff.
The caveat to that is if there's a crime being committed, then the sheriff's department is always the first place to go. But if it is, a disagreement about food or medications, or the patient wants to leave, those kinds of situations can be relatively common. And if the team can't manage it on their own, then they call the BERT team.
So in your opinion, do you think that the BERT team has been helpful in morale for our staff in terms of feeling that they have a backup and that they appreciate that?
Absolutely.
Very good. Any further questions on that?
No, just great numbers. The diversion rate, it's really, you guys are so impressive. All these things are terrific, really.
Oh, yeah.
Yes.
Well, as I said, the diversion rate, it's just amazing. You stopped reporting it when we were all.
Well, we picked
So
a good
you're
time
back.
just to bring it back because it's.
No, I think you should, because this is something the whole city looks at. Certainly city practitioners do. And whenever we're able to tell them that the county now is below 20%, I don't think we've ever been able to say that for years.
No.
So.
And just to touch on this next group of data. So it's worth looking to see that the ED average daily volume is still going up. And in part, that's because the diversion rate has gone down. We're able to accommodate more patients. And just so you know, we report here the diversion rate in May is 13.7. In June, it was even lower at 12. Now it's come back up a little bit in July for reasons that we can talk about when we talk about that next month, but it's still well below these high rates that we saw before. And I think I will keep myself from talking about it and defer to Gabe because I know that he will, but a lot of it is staffing. We are fully staffed in the ED now. And not just RNs, but nurse practitioners. Because the work that's being done, the improvement work that's been done in the triage area is similarly remarkable. The leave without being seen rates are also below. We've also met our goal there. And so all of that flow really helps in the emergency department significantly, even if we see more boarding. So similarly, the flow in the psychiatric ED, we pretty much addressed that when we talked about it for the strategic data. And the inpatient admissions and discharges, I'll defer to Gabe. Maternal and child health, there's not really any changes there. The data that you're interested in, we don't collect it in the same way we collect these data. We really have to go back and look day by day. Were we on diversion? Where did the patients go? So we're preparing that for you, but we're not able to report it in the same way that we report ambulance diversion, for example. Inpatient daily admissions and discharges in psychiatry are up, and that means we have better flow. Average length of stay, we'll let Gabe talk about that. As well as the patient length of stay in days. And then similarly, we have the lower level of care numbers that look really good. They're still not exactly where we want them to be, but the trends are much better. And I think I'll stop there and see what last questions you have before I turn it over to Gabe.
Questions? No, I think we'll look forward to the presentation. Thanks.
Thank you.
Shall we go? Is that a different item or part?
Yes, it's a different item.
Oh,
And
thank you.
I wish we had a bell, Dr. Ehrlich, that we could ring for the diversion and to congratulate you all, like at Trader Joe's because like how wonderful. Dr. Chow and I have been around long enough where this was promised many years ago, but congratulations on all the incredible work.
I will just say it really is a team effort. And the fact that we are fully staffed in the emergency department makes a world of difference. And the fact that we have flow, a better flow of patients also makes a big difference.
Very good. Well, congratulations, and we'll continue to follow that so that we can continue to brag about it. Thank you.
And I'll get that bell someday. Item 6 is the access and flow update. And just let me know when to go. Next slide, please.
Great. Good afternoon, Commissioner Chow, President Green, Executive Secretary Mark. My privilege to present to you the Access and Flow update. It is work co-sponsored with CIO Angelica Almeida, who's online, and Chief Nursing Officer Jillian Otway, who's here in the audience. And on the next slide, in terms of the agenda for today, going to be sharing a brief background overview of how we've organized the strategy, our KPIs and their respective run charts, which we've touched on a little bit already, and then finish with a review of the key countermeasures and reflect on some of the recent successes. On the next slide, as brief background, one more.
I know, sorry. I'm just, okay.
Here, just kind of very briefly, this work aligns with our quality pillar of our True North Pyramid, but it really does touch on all of the pillars: equity, safety, care experience, financial stewardship, workforce development. It really does touch on all of these. It's such an important strategy. And so and patients, of course, at the center and forefront of this, and kind of we'll hear a little bit about how the work really has impacted the experience of our patients in our different care areas. So on the next slide, as commissioners and President Green, as you all are aware, there are multiple factors that contribute to access and flow challenges, including increasing demands over time, combined with rate limiting factors like community resources, access to resources on weekends when things tend to slow down or not readily available. And the fragmentation leads to safety and quality issues as well as poor patient experience. That's kind of the background and kind of works into some of our problem statement for this strategy. On the next slide, as previously shared, we've revamped and reorganized through the Hoshin process how we're approaching access and flow to more holistically address all the factors that contribute and to incorporate just more system science into kind of making the improvements. So on this slide, you'll see our right care, right place key performance indicator and multiple countermeasures that are aimed at the two different aspects of the right care, right place KPI. The first part of this is pulling patients that belong in the health system into our care areas so we can take care of those folks. The second aspect is, can we transform our processes to think of alternative ways of delivering care and thereby offload the demand that the system experiences. So that's kind of the right care, right place KPI at a very high level, and you'll see some of those countermeasures there that feed into that. And then a kind of separate and related kind of feeding into the overall strategy are the patients who do belong in our care system. How can we minimize the length of stay to what's clinically appropriate so that we're not extending the length of stay to anything that includes an excess day or an avoidable day, but really keeping it to what the patient truly needs. And you see multiple different countermeasures there that I'll kind of reflect a little more as we go through the presentation. So on the next slide, you'll see how kind of the KPI table is organized. Really importantly to highlight, within each KPI, we focus on the key bottleneck areas across our health system that are often in high demand and often in kind of very limited availability. So we focus on our adult hospitalized patient care areas, and we focus on our psychiatric care areas. Often those are the two resource limiting kind of bed spaces that kind of feed lots of different parts of our system feed into. And so focusing on those for our KPIs in terms of our right care, right place KPI, we have a physical health line item and a psychiatric care line item, both using boarding. So kind of the way we're measuring right care, right place is looking at patients who are in the wrong place for their care. So it's kind of a defect metric and aiming to reduce that as low as possible. And so in the physical health row, you'll see boarding patients. So at peak during any given time, patients in the ED, ICU, or PACU waiting to come up to a med-surg care area. For psychiatry, it's the average length of stay measured in hours. For patients boarding in PS, looking to get up to an inpatient psychiatry bed. The second aspect of the strategy, clinically appropriate length of stay. Again, there's a physical health KPI and a psychiatric care KPI. Within physical health, we're measuring average length of stay, wanting to bring that down to as low as possible or what's appropriate, measured in days. And within inpatient psychiatry, measuring percentage of days that are acute or really appropriate for inpatient psychiatric care. Also on this table, you'll see our fiscal year 24 baselines, our aspirational benchmarks, and our 2025 targets for each of the KPIs listed here. And these will also be reflected on the run charts that kind of follow. So we'll move forward. The question is, how are we doing with these KPIs? And kind of on the next slide, you'll see run charts that reflect data through the end of June. And so on the subsequent slide, we start with our right care, right place. The first KPI, which in physical health is the number of patients boarding, waiting for a med-surg bed. We have tremendous success, as you can see here, in the months of May and June, where peak boarding in ED, PACU, and ICU areas dropped to 15 and 19 patients at peak in a 24-hour clock during those months. That's down from the prior baseline of 39 patients per day. And so while we're still off target for the fiscal year, measuring at 35 patients per day, boarding at any given time at peak levels during any given day, we've had, and while we've had some backslide in July, which we'll present next time we present this KPI to you all, this really truly is a reflection of incredible work of all of our teams and kind of the feeding of the multiple countermeasures, multimodal approaches towards supporting throughput through our different care areas. And I'll touch on some of the really important countermeasures. Susan mentioned the staffing, which has really greatly supported work in the triage area, and we'll talk a little bit more about those. I just want to highlight, this translates into the left without being seen rates being at all-time lows. It translates into ambulance diversion being at lows. It translates to higher patient experience scores and kind of net promoter scores of patients experiencing care in the ED has gone up in conjunction with boarding going down. On the next slide, I present to you the run chart for boarding in PS. Again, the second aspect of our right care, right place KPI. We continue to be at target for this for the fiscal year. PS boarding hours is down to 57.1 hours, our target being 57.8. Looking at our monthly performance in the black line, it kind of shows that we're pretty confidently projecting to continue to remain at target while continuing to decrease boarding hours, likely to slightly lower levels based on the trajectory of the black line, the monthly performance. And so those are our two right care, right place KPIs. On the next slide, we'll turn to the second bucket of this strategy, which is clinically appropriate length of stay KPIs. So for adult inpatients, the length of stay continues to be off target. However, there are some improvements. We aspire to get down to 5 days. We were there in the month of, I believe that's May, projected there. And again, attribute to the multiple countermeasures that we've kind of rolled out to support both leveraging partnerships with our skilled nursing facilities, so Laguna Honda and the Redwoods 4A SNF, moving patients there, leveraging community resources, especially enhanced case management through the San Francisco Health Plan and building partnerships there, analyzing avoidable days to kind of continue to target where are high yield areas for bringing down length of stay even more. And finally, on the last slide, or the next slide, I should say, in terms of the last slide, in terms of run charts, we have our inpatient psychiatry length of stay KPI, again, measured as % acute care days. We aim to increase this. We aim to increase the % of acute care days. For fiscal year to date, we are on target for this KPI at 21.8 of the days spent on inpatient psychiatry being acute. And our monthly performance suggests, again, in the black line, the monthly performance suggests that we'll continue to increase, likely to around 25% of days being acute. And then the success of this KPI linked really closely with strengthening partnerships with residential systems of care team, as well as our behavioral health center care areas, which provide kind of placements for our patients who are hospitalized in our inpatient psych areas and allowing throughput. This team has nearly doubled their kind of discharge rate, going from a little over 1 to 2 or more patients being discharged per day. And that's just a tribute to the kind of all the hard work, and proof is in the run charts in terms of the dramatic improvements that we can see in terms of increasing now the percentage of days that are acute or appropriate. On the next slide is really kind of a summary of our problem statement. Given the interconnected nature of our different care areas, it really a problem statement calls for a comprehensive system science approach towards deploying our strategy. And so on the next slide, I'm kind of reflecting on the countermeasures that we've rolled out. On the top of this slide is a mini driver diagram, which I think highlights how each of the KPIs are supported by different approaches that feed into the KPI. So for right care, right place, I mentioned kind of offloading demand, so coming up with alternatives for being able to care for our patients, as well as strategies for increasing appropriate streams of patients. On this slide, you'll see some of those countermeasures. So in alignment with increasing appropriate streams, the ED nurse practitioner and nurse staffing in the ED has allowed us to really stand up our triage task force and care start workflows in the front of the ED to maximize pulling patients in who belong and jump-starting their workups so that patients do not leave without being seen and actually feel like they're being attended to. As mentioned, this has dramatically improved our patient experience scores because patients are being seen in a timely way and not waiting for extended periods for their care to start. In the offloading demand aspect of this, of the right care, right place KPI, things like dalbavancin, the long-acting injectable antibiotic that has allowed us to discharge patients who otherwise would have been admitted for intravenous vancomycin. We estimate that we've saved close to 180 bed days by using that countermeasure, saving those 180 days for other patients who need their care. As mentioned, as Susan mentioned, we've been seeing actually more patients in the ED, not less. And that's really a tribute to the improved flow and all of these kind of really important countermeasures. On the length of stay driver diagram on the upper right, I'll just kind of turn your attention there. There are three different strategies there: removing waste, increasing coordination, and enhancing or leveraging community resources, partnerships, and connections. So on the next slide, you'll see reflections of those different strategies. So in line with removing waste, really addressing lower level of care patient days and trying to maximize movement of those patients to their next place of healing and what's most appropriate for those patients. Also, we're trying to learn more by exploring what contributes to an excess or avoidable day in the hospital in partnership with our KPO and Project Phoenix, kind of really trying to value stream map kind of prototypical patient diagnoses or patient types and seeing what can we learn around the efficiency of care within our system. With respect to increasing coordination across our different care areas, the 9th operating room has really dramatically improved our ability to get patients who are hospitalized waiting for a surgical procedure in the operating room, sped up their ability to get access to those procedures, so not waiting for surgical procedure and thereby decreasing their length of stay to a more clinically appropriate number. Working now, our med-surg team actually just this morning presented in our hospital's flow committee work aimed at improving the timeliness of discharge, so minimizing the time from the discharge order to the patient leaving the hospital. And part of that will be making the most use of our discharge waiting room for patients who are appropriate, who can wait in a separate waiting room area, to then free up that bed to be cleaned so the next patient can come up and we complete the discharge process in the waiting room where if they're waiting for a ride or waiting for medications, that can be done, and maybe potentially even adding to the quality of care by doing educational interventions while they're waiting in that area. And then in terms of, in the spirit of building community partnerships and leveraging community resources, we're have a really great partnership with the Redwoods, the 4A SNF. We've gotten over 80 patients there in the last 4 months. Also leveraging our connection with Laguna Honda and, as mentioned, the residential systems of care and behavioral health, long-term beds, and building partnerships with the San Francisco Health Plan and enhanced case management. So kind of those are the countermeasures, how they're kind of organized in terms of how they feed into our KPIs. And then the next slide, I'll kind of focus a little bit more on some of the recent successes. So as we've touched on, left without being seen rates are down to 1.8%, which is just tremendous. And kind of, I've mentioned what that really means for the patient experience. 180 bed days saved by using dalbavancin in the peri-op area by leveraging the 9th operating room resource. An extra 50 cases were performed in the operating room in the month of March. That translates into decreased waiting in a hospital bed for those services and decreasing length of stay. I mentioned the Redwoods 4A SNF. We've gotten 86 patients in the last month. That's 20 patients a month. And counting, and that team's doing remarkable work in partnering with our inpatient teams at identifying patients who are appropriate. In specialty care, ensuring we've maintained a TNAA rate of less than 15 days. And that's kind of built upon decreasing no-show rates, enhancing or decreasing out-of-network referrals into our specialty care areas. So we reserve our slots for patients who have no other alternative for care. As well as the team is looking at the specialty care clinic templates to make the most of how we structure our clinics to be able to get, let's say, emergency appointments in a timely manner and ensure access. And our Department of Care Coordination continues to partner with Laguna Honda. There's been tremendous progress. Our average days to decision is now down to 4 days, which is really impressive. And we've gotten 128 patients admitted to Laguna Honda since they're recertified and reopened to referrals from the hospital. There's just tremendous partnership there, and looking forward to continuing to build on that. On the next slide, so those are some of the successes. On the next slide, this is an example of how we're disseminating the progress and kind of trying to increase alignment as well as awareness and get folks invested in and interested in the work that's happening across the campus and inviting them to be a part of the flow work in their respective care areas. It's a one-page summary of what we discuss in our hospital's flow committee. There's also a survey that invites folks to submit their ideas and their kind of reflections on what's working with flow or what's not working with flow, and a brief summary of our KPIs at the bottom. This is a nice kind of visual way of summarizing a lot of work and kind of celebrating the teams for the impact that they're making, as well as inviting input on the process. And that concludes, on the last slide, that concludes the Access and Flow Strategy Summary Report. I want to thank you all for the opportunity. I want to thank all of the teams, I think most importantly, who are doing this work. Again, thank my executive co-sponsors, Angelica and Jillian. I want to thank Chief of Performance Excellence, Hemel Kanzaria, and the KPO for all the support that they've lended to this in terms of helping to organize our teams and aligning our strategy. To Susan for all the support that she has lended in terms of all this tremendous work. And kind of just to summarize, we continue to make a lot of progress. 2 of the 4 KPIs are on target. The other 2, while not at target, are showing some really impressive improvements. And with that, I will pause for questions and comments. And I have a great team supporting me. I have Angelica and Jillian here to also answer any questions that may come up. So thank you very much.
Commissioners, there's no public comment, and I'm going to run to the bathroom while y'all.
Okay, Commissioner questions.
So thank you for the terrific presentation and to all the teams for this amazing work. I mean, I look at so many brilliant solutions like the discharge room, which is really one of the #1 reasons why people don't leave the hospital, and the number of hours, especially because I know you've had issues with the turnaround time for room cleaning, and it sounds like this is a wonderful solution. As you say, on top of that, you can do education in the interim. So that's really fantastic. I was just curious, it seems a little odd to me that the benchmark for inpatient acute psych days was 44%. What's going on out there in California that lets other people have 44% appropriate? Is it coding? It just doesn't seem logical unless we're comparing, private hospitals to, public hospitals.
Yeah. Well, thank you for that. Before jumping into that, just acknowledging the comment on the discharge waiting room. Our leadership team on MedSurg, Tanvi Bhakta and Lisa Winston, are really excited about deploying the discharge waiting room and making the most of that kind of experience for our patients. No one likes to move a patient out of a room that they've been in for a few days. And so trying to make it as patient-centered as possible while supporting all the operational work just again highlights how our teams keep the patients at the forefront of all of the great work, and really excited. They presented this morning about some of their plans for how they might leverage that, identify appropriate patients, et cetera. And so we're really excited to see how that will kind of roll out. To your question specifically, I have Angelica on the line who probably can speak much more eloquently. We set our standard by the California kind of benchmark for the state. I think 44% seems like not a great number, and at the same time, I think it speaks to the limited resources as we've experienced in terms of building partnerships with LSATs, psychiatric skilled nursing facilities, and other placements for our patients who are experiencing mental health crises. I think they're just limited options, and so as a result, patients get stuck in our inpatient psychiatry areas across the state, waiting for resources in the community to be identified, or their psychiatric emergency to be stabilized to the point where they can return to more available community placements or even their homes. And so I think it speaks to just resource limitations, and we're hoping that kind of looking at the needs of our patients, especially those who stay for a long time, trying to define what are the resources that we need more of, kind of in partnership, Todd Barrett, our CMO, Roland, our CEO of the Health Network, have really been pushing us to kind of ask that question: what is the resource? What can we learn from the data and kind of our past experiences to then advocate for how we can manage behaviorally complex patients and really have them move smoothly through our health systems. But Angelica, I saw you came off camera. You're welcome to chime in and really dive deeper.
Thank you. And I apologize for not being there in person. I'm home with a sick kid. So really appreciate the question. And I'll just say, I think it's twofold. There is both the criteria for acuity is very high. And so I think across the state, what many of us see is that somebody may no longer meet the criteria for an acute stay, but that doesn't mean that they're ready and stable enough to discharge to the community successfully. So there's both that, and certainly the challenges that Dr. Ortiz mentioned in terms of alternative placements, locked facilities. And I think we see that really highlighted in the Bay Area, being in a concentrated area. We are all competing for the same beds. And so while it's a challenge across the state, I think we see it to a different degree in the Bay Area. So both of those things combined, we see this as an issue. It's certainly not unique to us, of course, but I think we've made some great progress with standard work, partnering very closely with the community, the advancements and resource investment that behavioral health services has made. We've just done a lot of work relationally with our providers and our social work teams to really be aggressive in identifying discharge places and figuring out how we get to yes, to get people to the next level of care, and identifying what additional supports we can offer to placements to make that happen, which can also include that people return to the hospital to enforce medication orders, for example, so that's not a limiting factor for people moving to the next location.
So but the 44% data, does that include private hospitals in the state where the people who are discharged clearly have more resources? Have they broken it out according to DISH hospitals that are more similar to the general than what private hospitals might have access to?
It includes all hospitals, but I haven't seen it broken out by public hospitals versus private hospitals. We can certainly see if there's that additional information, but I haven't seen that level of granularity.
Yeah, I just wonder if you're actually doing a lot better and it's a matter of being compared to hospitals where patients have far more resources and options than the patients that come to the general might have. So I mean, you don't have to go to any trouble, but I was just curious whether that was part of it.
No, appreciate that. And I will say, I think something that's interesting in our healthcare system is that in terms of inpatient placements, there can be more options for individuals and for that acute psychiatry. But actually, when we're looking at alternative placements, locked facility placements, et cetera, we actually see a broader range of services that we're able to provide as a health network. And so in a lot of ways, our patients are better positioned for ongoing placements.
Thank you.
I was wondering on the discharge waiting room, and your comment, of course, is appropriate patients now go to another room, but how long do these patients stay before they really get back to their own abode? And is this a room in which, let's say, often what happens is we're waiting for a doctor or a appliance or something to come before somebody leaves the room, right? We look at sort of the typical discharge, or meds, or transportation, or the family, or something.
Right.
So at what point do you say, does the doctor come in and say, I'm putting you in the discharge room and you pick up all your meds there and they'll make all your arrangements for the transportation? Or we're making that all up here and you go to the discharge room and you wait for all these things to happen? I mean,
Yeah.
how is the flow for that so that the patient experience, as you were pointing out, would be positive rather than I've just gotten moved to another room. These people don't even know me, and I've had to go up and talk to them and say, where's my meds or something.
Yeah, great question, Commissioner Chow, as always. So the team is working on the standard work for how there'll probably be multiple PDSA cycles. It's been the early stages of getting rolled out. Kind of to your question, it likely will be kind of on the order of hours in terms of waiting in this waiting room for things like your last prescription kind of needs to come up from the pharmacy, or we're waiting on a ride and your loved one is at work and they can't get here until after hours. And so we have this kind of patient-centered space for you to be able to wait for that ride so that we can kind of free up the room. Really intended for patients who are more ambulatory, who are kind of cognitively intact, I would say. And so the team is kind of devising or defining kind of the eligibility criteria, and then the thought process is the patients who are being discharged, if there's a discharge order in place, and the discharge process has started in terms of the final stages of the hospitalization, eligible patients can be flagged by our nursing teams, and then provider teams can be made aware, hey, the last few stages for this patient will be finished in the discharge waiting room in case there's anything that you need to kind of wrap up in terms of your communication or part of your work. And so it really is not intended to be a long stay area. It really is the last few hours of a hospitalization, just to kind of get the most out of decreasing the length of stay. And also on a day-to-day basis, those a few hours can actually mean a world of difference for someone who's waiting in the ED or waiting in the ICU to come out to a more appropriate care area. And so kind of we want to make sure that the patient themselves have a great experience. That's kind of targeting education and other things and bringing those to the patient in the waiting room, while also kind of making the experience of the patient who is waiting in the wrong place much safer and much better as well. So it's kind of dual benefit is the hopes.
So it sounds like you're working on exactly how this is going to flow, and I think it'd be good to come back and let us know as you've got this, and got some data on how long it would take. And I might mention just on a personal basis, that happened to me having gone down to not a waiting room, but we were being transported out. Okay. But it was so nice. I mean, they transported me quickly when I didn't have a chance to get the very nice cup of coffee that UC has. And but I think the point there was an amenity of some sort would be helpful for the type of patient you're talking about that's ambulatory,
Right.
because it kind of makes them feel it's the same as when you go to the airport, right? And if the waiting area had a little amenity, it isn't so bad waiting. And that's why I guess they put in all these plugs for everybody to be able to.
I love it. I love that the marketing strategy there. Make it like the United or Delta Lounge, not the gate area.
But I think some sort of amenity said, because otherwise somebody's just sort of waiting and they're not distracted enough to really feel comfortable as the minutes drag on. That's all.
Yeah, I'm happy to come back and present the progress made on this one.
I think that'd be nice to understand how well it's working, and it's kind of like the obverse of the emergency room admission,
Yeah.
where now can we have a nice way of having people be able to vacate their room comfortably, and maybe even move the process faster, right? So. It was a very nice presentation. I want to just compliment you on that, because I think it gives us a very good idea of what you have all been working on, and some of the initiatives, and perhaps it would be also appropriate to, as much of this is sort of a preliminary. I like the flow strategy driver slide because it shows so many different initiatives that you have, so that I think when you come back with the follow up on the discharge room. Maybe you can tell us where some of these are at in terms of how it is working out for the flow. So
Happy to do so.
it's a different kind of flow than we've been challenged with in the past, but I think just this page, I think, tells a lot, by the way, in terms of putting it all together. So really want to thank you for that. Any other comments, Commissioner? Very good.
Thank you very much.
Thank you.
We can move on to item 7, the medical staff report.
Good afternoon, Commissioner Chow, President Green, Mary Mercer, Chief of the Medical Staff. Great to see all of you. So I'm pleased to present our medical staff report for July, where we cover a number of items. The first of which is our pediatric service report. And I thank you again for your questions. I did answer some of them or most of them via email, but I will touch on some of those responses briefly here because it was an extensive report. After the service report for our pediatric service, I will go into our credentialing committee matters. First for our pediatrics report, the chief of pediatrics, Dr. Jane, presented the report and really gave a wonderful summary of the diverse clinical offerings and the people and diverse clinical teams that make up her team. It highlighted their 3 main service areas: the inpatient services, our infant care, and the ambulatory care operations, which are also widespread and diverse. I think she highlighted the inpatient service that really has a number of experts in inpatient care for children with medical emergencies, particularly in that a lot of the admissions are related to complications relating to respiratory illnesses. And I think throughout her report, she really highlighted the collaborations across clinical services and interdisciplinary teams. She highlighted that due to their relatively small size of our inpatient services, there is a number of cross collaborations with our medical surgical units where patients over age 12 can also be, if we have a surge in respiratory illness, for example, some patients in the older ages can be managed on the adult services floor with consultation to pediatrics. And how for our trauma services in particular, they rely on a lot of interdisciplinary management between the trauma service team, our pediatrics team, emergency team, neurosurgery, other surgical specialties, with excellent MOUs with our area hospitals for the care of critically ill trauma patients. In the infant care center, something I did want to highlight, in addition to our NICU capacity, there's been a really great improvement and engagement with interdisciplinary collaboration between maternal health in the treatment of infants that are suffering from substance use dependence, and really great collaboration with Project Lily. And so there's been increased capacity and improvements, but also that's an area of strain, and that as we are a center of excellence for the management of mother and baby with substance use disorder and dependence, that can put strain on our patient care beds, because their length of stay can be quite long in the NICU following that. Additionally, she highlighted the collaborations and innovations of the ambulatory services. So she noted the high volumes in our urgent care center, the reliance and collaboration was highlighted from our affiliation with UCSF with a range of number of specialty and subspecialty services that are available both through telehealth as well as through courtesy faculty, courtesy medical staff that have periodic clinics, as well as MOUs. And then a particular highlight, the pediatric service really has a broad range of quality improvement initiatives really many of which, most of which, I haven't done the exact calculation, are focused on equitable health outcomes. And one that was particularly highlighted in prior reports to this body, but that was highlighted again in the service report, was the Honeycomb Clinic, which is a program for the primary care ambulatory care clinic that sought to improve health outcomes for racially diverse, but particularly for our Black and African American pediatric patients. And one of the highlights of this is that the clinical interdisciplinary clinical team went to the patients very appropriately and asked for their input on what would make a difference. And one of the interventions was having racially concordant providers. And so there was restructuring involved and trainings, and what they saw was a significant improvement in well child visits, immunization uptake, and other health outcomes in our Black and African American identifying patients and families. And so that the learnings from that Honeycomb Clinic are now being spread through to other groups and interventions within both ambulatory care and other components, both the pediatrics and in adult services. And then she highlighted a number of other accolades for the faculty, for their educational missions, and national recognition. Again, a lot of it grounded in the quality improvement work that they have innovated in. I'm happy to take any questions that you have about the pediatric service report. There were some specific questions you had, which I will just touch on briefly here. Actually, they're in some of them are in the privileges list that I can get into, but there's some question around how specialists interact, what the impact of Mission Bay has been. And I think overall it's been very positive, and that there have been more robust consultation agreements, MOUs, as well as an expansion of courtesy faculty, and particularly for the neonatal call coverage, we're working on some improvements to expand neonatal call coverage. Even though there may be one, neonatologist on call at any given time, it's covered by a number of different clinicians.
And there's no public comment on this item.
Commissioner, comment or?
There was a question, they answered most of them.
Yep. Then the other part was their rules and regulations. I can cover that if you'd like, unless you have a question about their service report itself.
Well, it was certainly a very comprehensive report, and the PowerPoint was even, more very impressive, as are the PowerPoints of most of the departments that we have been able to see. So.
Yes, and I think in this one we printed it out, but perhaps we're moving back to electronic if you prefer.
Well, I happen to prefer it printed.
Okay. So Commissioner Green, did you have questions?
So
I think you were going to try to get some data about the diversion rate
Yes,
slide.
unfortunately, I do not have the data on the diversion rate yet for that, but we'll work with Chief Jane to get that information.
Great. Yeah, I have no other questions.
okay, so let's go on to the.
So the other part.
Your other section with the rules, regs, and so forth.
Yes. So the other section for the rules and regs, there are very limited updates for the pediatric rules and regulations. There was just some minor changes to and details to the job description of the vice chief of pediatrics. They updated the names of the personnel who were in the department due to leadership changes with it since the prior presentation. And then there were some wording changes around their roles and responsibilities, as well as just formatting changes for privileges. There were some questions around the general privileges for neonatal privileges, and just a question around the performance, particularly around pericardial tube placement for pneumopericardium. And that I noted that was included in the general privileges, unlike, for example, central line insertion might be its own privilege because it's a more common procedure. But if someone has met the criteria for general privileges through training in neonatal specialty services, then they would have received certain amount of training in pericardial tube placement, though it's a very rare procedure. So I wanted to clarify if the commissioners would like data in the future via email on the number of those procedures are performed. I didn't have that readily available, but the medical staff do maintain ongoing competency through simulation if they do not have the same number of procedures.
Commissioner, any other?
Just some keys for this.
Okay, so
And then would you like me to move on to the credentials committee report?
let's make sure that we've because we just got these just
Oh, sure. So those are just the responses for the clinical service report for pediatric rules and regulations and their service report.
right.
And then there are several standardized procedures and privileges that were updated through our credentials committee work that I am happy to summarize what those updates were. And then there were some questions about them.
All right, there are some corrections in here already and comments that okay. All right, so these appear to have answered the questions, and I do remember that when taking my children to get shots, nobody gave them anything.
Right.
So you're being very compassionate.
Oh, yes. Yes. So I'll just briefly cover our standardized procedures. So there are some updates with the psychiatry standardized procedures with regards to location, as well as scope of practice, et cetera. Neurology, there's update on the protocol around Botox, standardized procedure for Botox administration by nurse practitioners or PAs. And there was a question from all of you around there was a correction around what it was asking for the attending documentation. So as you may have noted in below the diagnosis and treatment, or the diagnosis component in the treatment component of the Botox protocol, it does specify that all patients that are receiving this treatment need to have attending consultation. So there's the documentation component, as well as all of them are receiving consultation with the neurologist, in addition to the nurse practitioner and PA. But it is part of the standardized procedure for the nurse practitioner and PA to perform their assessment, including a differential diagnosis, when presenting to the attending.
So the protocol actually calls then for them to present basically to the neurologist?
Correct.
Before proceeding with the
Yes.
procedure.
So many of the standardized procedures are written in such a way that there may be indirect supervision and always an attending available. In this particular procedure, it does say that anyone undergoing that treatment must have a consultation with a neurologist.
Okay, I guess that answers both of our questions that came up. On that one, you have other?
And then,
Yeah, so the only real question I had was this issue of, by law, we have to give this blood transfusion trifold pamphlet from the state. And I don't know, given the diverse languages that, you see among your patients, I don't know if you can see this, but this is it. I mean, I have it in my phone because I email it to people at 28 weeks because we have to give it to every pregnant patient. And I don't know if you can see this, but it's a trifold. And I know the answer. You can take a look at that.
yes.
It's, the answer was, well, there's a translator, but I think it probably does need to be translated. It's way too much stuff to have someone go line by line by line to translate
Really?
that.
7 pages?
Yeah. Well, no, that's not, well, yeah, if you count the trifold, it is.
Oh, yeah,
So-
okay.
So you know, I just encourage that because I think it's a legal requirement. And I know there are a few languages it isn't accessible, and I can email it to you if you want it, but
Yes, I do have, I am sending that along to our interpreter services. For our, I thought the question was asking specifically about our consent forms, but I will ask about that form in particular.
I shall send it along.
Yes, and then I think as was alluded to in pediatric urgent care, there are a number of nursing standardized procedures that were developed to initiate care specifically around acetaminophen or other analgesic medications, and then some medications as Commissioner Chow noted for oral sucrose as a distraction technique, which is very, very, very successful.
Yeah.
Yeah, it works better than a dorsal penile block for circumcisions. It's amazing. The sweeties are just incredible.
But you mentioned a great point that in our standardized procedures, and if you look at the other ones around medication administration, there wasn't a particular component of the standardized procedures that discussed consent. And that is in, my understanding is that's in another standardized procedure for nursing. And so we will get that documentation to you and or make reference to it we'll have to do a holistic update to our standardized procedures for medication administration, just to specifically call that out.
Okay, so we need,
And so I guess the other questions were related to the sidebars, which you said.
And then the final,
Yeah,
mention, the
that's-
correction, thank you for the correction on the sidebars, which we did note, and we will remove those from future track changes because it was, it highlighted discussion that was had in CIDP, but it really wasn't relevant to the track changes that are helpful for review at this committee level.
Okay, any other questions? If not, then a motion to
I moved.
recommend to the commission the pediatric rules, regulations, and from the credentials committee, the revised standard procedures.
So recommended.
And second, I will.
All those in favor?
Aye.
Right.
Thank you so much. Thanks, Dr. Mercer.
Thank you.
Mercer. We can move on to item 8, the other business. Hearing none and seeing no public comment, we can go on to public comment. There is none today. So please consider a motion to go into closed session.
Move to go in closed session.
Second?
All those in favor?
Aye.
Aye.
Great. Could someone please close the door? Okay, so we're going to have 2 parts of this closed session. The first is kind of regular, but when we get to the third, I'm going to make sure that only folks who should be in the room should be in the room, just FYI. Okay, give me a second to take us down. Folks who might be watching this now or later, you won't see us while we're in closed session, but we will be back. Okay, give me 1 second. You, in closed session, you approve the credentials report and the PIPS minutes report. Please consider a motion to disclose or not disclose other discussions held in closed session.
Move not to disclose.
I would second that.
All those in favor?
Aye.
And then please consider a motion for adjournment.
Move to adjourn.
Second?
All those in favor?
Aye.
Aye.
Thank you.
Thank you very much. Thank you, Glenn.